So, a very good evening to all, and welcome everyone on this World Stroke Day to our webinar on stroke awareness and prevention. Today, we'll be addressing a crucial health challenge that is significantly impacting India. Stroke ranks as the fourth leading cause of death and the fifth reason or the leading cause of disability in India. Stroke, unlike in Western countries, a significant number of these stroke cases in India are usually seen in patients below the age of 65 or even more, 20 to 30% of them, even at a lesser age, that is 50. So, to understand this concerning trend, we have two eminent speakers for today. And it's my honor and privilege to introduce our speakers to you today, the two exceptional leaders in neurology who have pioneered advancements in stroke care across India. First, we have Dr. Shirish M. Hastak, consultant neurologist and the regional director of neurology, stroke, and neurocritical care at the Gleneagles Hospital, Mumbai. Sir has been instrumental in advancing stroke care, and his notable achievements include establishing the very first stroke unit in Western India and founding the country's inaugural stroke helpline. Recognized as the inspiring neurologist by the Economic Times in 2018, Sir's impact in the field is a testament to his dedication and vision. Sir, we are gladly welcoming you to our session for today. I'm
Thank you.
honored to have you here.
Thank you,
Next,
Dr. Anuja.
Next, I'm equally honored and delighted to introduce our second speaker for today, Dr. Subhash Kaul, Senior Consultant Neurologist at KIMS Hospital, Hyderabad. Sir has held an impressive range of leadership roles throughout his career and an extensive experience in stroke research and clinical neurology. With over 120 research publications and fellowships with the American Academy of Neurology, American Stroke Association, and the Royal College of Physicians, Glasgow. Sir has made significant contributions to advancing neurology in India. Sir has also been recognized with the State Teachers Award by the Government of Telangana. He has held prestigious leadership positions as the past president of both the Indian Stroke Association and the Indian Academy of Neurology, underscoring his commitment to the field. We are privileged to have you, sir, and glad to have you over here to share your insights with us. So without any delays, I now hand over the session to Dr. Shirish, sir, and we encourage the participants for their active participation throughout the discussion by sharing your thoughts and questions in the chat box. So thank you so much. I hand over the session to Dr. Shirish.
Thank you, Dr. Anuja. I think I will start sharing slides so that, Yeah, okay. So, friends, thank you for joining us on this World Stroke Day webinar. And, it's a pleasure to be with Dr. Subhash Kaul, who has been my absolute, bosom pal for stroke, and also a great friend. So, friends, when myself and Subhash started our practice, I think over 35 years ago, approximately, and Subhash would always say this, that stroke was a veranda care approach. That means you put the patient in the veranda, and next day, if he was all right, you were okay with it. From that time, friends, I think, the changes started happening. And so the window, and today I'm going to speak of this acute ischemic stroke within the golden hours. So the golden hours then came up to 3 hours and then went up to 4.5 hours. And then came the idea of moving it beyond with mechanical thrombectomy, which was 6 hours, and then came the 9 hours, and then the 16 hours, and then the 24 hours. But I think time has to ultimately go outside the window completely. And probably it will be tissue which will determine what you can do to your patient and what you can't. Because I think all of us realize at some point that you have this patient who comes in at 1 hour uh, or 2 hours, and you do whatever, you do thrombolysis or you do mechanical thrombectomy and so on, and the patient doesn't recover. On the other hand, you have these patients who come in at 6 hours, and you do their mechanical thrombectomy or thrombolysis, and they do well. So I think no two patients are the same. So I think it's very important for us to understand that there will be, sort of rapid deteriorators and slow deteriorators and intermediate deteriorators. And so you need to keep your thinking open. So this golden hour concept, I think, still holds true, but I think over the future will be tissue based, thinking in terms of the and not just time based idea. So that was the first thought. The one thing about medicine is that medicine is a science of uncertainty and the art of probability. So in medicine, you will always have some uncertainty and some probability titered in into your thinking. So you need to titre in both these facts, and it's a science and an art in combination with each other. And Sir William Osler said that so many years ago. So the first thought you have, of course, when you have an acute ischemic stroke, and you are looking at within the golden hours, today I'm going to consider the 4.5 hours, friends, since I'm not a person who does mechanical thrombectomy, and so I will consider the 4.5 hours as the golden hours for today's talk. So the first thought is this a non-stroke or a stroke? So in the non-stroke, we all have seen that there can be a seizure, and seizures, if they are not witnessed, then you really uh, are unable to make a clear-cut diagnosis, especially if there's a Todd's palsy or there's altered consciousness following the seizure, and no one witnessed the seizure. You can think of this as either a cortical infarct or a brainstem infarct. So seizure is one of the differential you must be careful about. The second differential is a syncope. Syncope is a little easier differential, older people going to the washroom, falling down there, becoming unconscious after passing urine or stool. More likely syncope, less likely stroke. Encephalopathy can also be a differential. And encephalopathy is not necessarily rapid, or sorry, not necessarily slow, because stroke is rapid and encephalopathy is slow, as per classic teaching. But I think time and again, myself, Subhash, and others must have seen that the hyponatremia can be a rapid presentation of a stroke-like phenomena. So can hypoglycemia, but hypoglycemia is of course easier to diagnose, whereas hyponatremia or sometimes even hypomagnesemia can present uh, like an encephalopathy, and so you can really confuse this with a stroke. Head injury, of course, subdural hematoma is a classical masquerader of stroke. And if you haven't taken the history carefully, you haven't asked them history of a fall or haven't looked at your patient carefully, and you can miss a subdural completely. And we have all been surprised by a subdural when we thought that this was a stroke. Hypoglycemia, of course, now doesn't remain a big differential because you usually do the HGTs of patients as soon as they come in, and you have a sugar below 70, this is hypoglycemia. But the big ones are seizure, syncope, encephalopathy, and head injury. Having said this, I think, as I said, today we will consider only the 4.5 hours as the golden hours. You all know that mechanical thrombectomy golden hours have gone up to 24 hours. So we activate code white or code stroke in all our patients who are within the first 24 hours so of their onset of stroke. What is next in stroke? So next in stroke, I like to think about this as the classical ABCs, but I like to make the D as DQ. So ABC is the standard ABC airway breathing circulation, which we all know. But the D cube is an addition I like to think about. So the D cube consists of duration. That means when was the patient last known well? What is the deficit in terms of NIHSS and GCS? And what is the drug? So is he on antiplatelets or anticoagulants? So this, when the people call me that this is a stroke, I'll usually say, what's the ABCD cube? So ABC is a simple, well-known. The D cube is the duration, the deficit, and the drug. And I think this is good enough information to begin with in terms of the acute stroke that you are dealing with. So the duration, of course, the last known well, you have to assess carefully. And especially today's focus is the 4.5 hours. You're considering IV TPA or now, of course, TNK as well as the drug of choice. Between 4.5 hours to 24 hours, you consider endovascular treatment. There's one other thing that I always like to think about when I'm looking at acute ischemic stroke is that how was the patient before the stroke? Because you need to know that this is not a severely demented bedridden patient. that you're taking up for either thrombolysis or mechanical clot retrieval or aggressive forms of treatment. So I think how was the patient before the stroke is a question you have to ask yourself all the time. The deficit, of course, you have to look at the NI stroke scale, and I think NI stroke scale is pretty well standardized now, 0 to 42. 1 to 4 is mild, 5 to 9 is moderate, and greater than 10 is severe. Glasgow Coma score, of course, 3 to 15. And if it's less than 8, you consider intubation. Now, remember the GCS, the Glasgow Coma Scale, is a global score. And of course, my neurosurgeons love the Glasgow Coma score. And the neurologists love the NIHSS, which is more the focal score. But I think you have to combine the two in order to make a proper decision for your patient of acute ischemic stroke. So I'll usually ask, whenever we get an acute stroke patient, what's the GCS and what's the NIHSS? And knowing both will help me make decisions quickly. Imaging, you need urgent, you rush your patient to an MRI brain with MRI angiography brain. This is our bias. We prefer the MR angiography brain because we can do it in about 15 to 20 minutes in all our patients. So this is a bias we have. But in case patient not cooperative, pacemaker, aneurysm clip, recent metal insertion, you can do a CT scan, CT angiography, and I'm sure there are lots of centers which still prefer CT scan, CT angiography. And it's fair to do any of these imaging tests, if so long as you can do them within 10, 15, 20 minutes. And you don't need a creatinine report in these patients. It's very important for you to tell your radiologist that there's no need for a creatinine report in the acute phase of stroke, and you can go ahead with imaging rapidly. So it can be an MRI, MR angiography, or a CT, CT angiography, whichever is available to you rapidly. So the imaging report, usually we urgently send this imaging report to a consultant on code stroke on WhatsApp group with add doctor so and so on on this. The add doctor is important because you have multiple consultants in the hospital. So the consultant whose patient it is needs to know that this is for him. So we have, of course, a code stroke group, and we put all our acute strokes within the first 24 hours on the code stroke. If the patient is outside the 24 hours window as of now, he doesn't come into the code stroke group. The MRI, which we have a preference for, the DWI, tells you the high signal and suggests a stroke. If the ADC in the same region where the DWI is high, then you know. If the ADC is low, the DWI is high, this is most likely an acute stroke. If you have an SWI low signal, you are aware that this is most likely a bleed. The flare, I'm sorry, the flare suggests whether this is the 6 hour or outside the 6 hour window. The MR angiography also tells you what is happening to the artery. You can also do a CT scan or CT angio, which also gives you information about the parenchyma and about the angio. We discuss this with the radiologist urgently and make a decision quickly. The eligibility for IV thrombolysis is pretty simple now. And in fact, myself and Subhash were discussing that probably only the intracerebral hemorrhage looks like it will remain in the future as a contraindication. But as of now, we do look at NIHSS. If it's less than 5 NIHSS, if it's more than 5, of course, I think the thrombolysis idea is pretty simple. But if it's less than 5, I usually ask my resident, is there a PDND? By PDND, we mean, is this potentially disabling neurological deficit? That means, this hand, right hand, which has become, this is NIHSS 1, but this is potentially disabling since I'm a right-handed guy. And even if I'm NIHSS 1 right now, you will consider me for thrombolysis because I am potentially disabled. The blood pressure, of course, should be less than 185, 110. There should be no ICH, as we have said, and there should be no massive brain infarction. Of course, the thought is that you can thrombolize even when there is big infarction, but usually you will need to counsel the relatives. The outcomes are poor, and I think you need to think about it carefully. You of course rule out a hypoglycemia, and you also start two IV lines immediately. Eligibility for IV thrombolysis, you also think about that patient is not on any anticoagulation. If on warfarin, INR should be less than 1.7. This is a difficult thing to achieve at times because you really don't get the INR so rapidly. But I think if the patient has taken warfarin, within the last 24 hours, you really have to be careful. And of course, you also should remember that the warfarin effect lasts for long, unlike DOACs. So, warfarin is really, you have to be careful. If on DOAC, avoid thrombolysis unless patient has not taken a dose of DOAC for last 24 hours. There's a little bit of controversy here, and some suggest that it should be 48 hours. No recent surgery, of course. If you have a recent surgery, if it's at a compressible site, then of course there's no issue about thrombolysis. But if the recent surgery, especially if it's a major surgery within the last 1 week or 2 weeks, and if it's a thoracic or an abdominal surgery where you cannot compress, or especially if it's a brain surgery, no question of compression, then you have to really worry about thrombolysis. Compressible site, you can go ahead with thrombolysis. Now, I'll just discuss two quick cases, before I hand over the session to Dr. Subhash. So, 62-year-old male, known hypertensive on treatment, came to the ER at 10 p.m. with drowsy state, sudden onset of loss of consciousness while taking a regular walk around 8 p.m., regained consciousness after 1 to 2 minutes, no witness seizure-like episode. So we did think clinically. I mean, is this a rapid encephalopathy or is this a stroke? The hemodynamically stable, blood pressure 140/90, stupros, opening eyes to deep pain, moving all four limbs spontaneously. But here was the tip-off. There were two tip-offs. One was that the pupils were pinpoint, sluggishly reacting bilaterally, and there was a downward gaze deviation. And we looked at the NIHSS, and it was around 20. And this was his picture, and you can see clearly that the pupils were small and the eyes were clearly deviated down. So this was the tip off, which if we had missed, just because we thought this was a encephalopathy and not a stroke, if we had missed this, we could have missed the bus. But of course, the imaging showed us that they were bithalamic infarcts, and this is the diffusion which showed a high signal, and the uh, ADC showed a low signal, confirming that these are infarcts in the thalamus. We, of course, did the angiography, and the basilar was open. The PCS were open bilaterally. They are not very well seen on this picture, but they were open. And we did an venogram as well because sometimes the venous infarcts also can look like that. Usually they are hemorrhagic and not so much territorial as you see in the arterial infarcts. So this was an acute stroke with artery of Percheron infarct, and in the window period of IV thrombolysis, we thrombolized him with IV TPA 60 milligram. We gave a 6 milligram stat, a 54 milligram bolus over, sorry, not the 6 milligram was the bolus, 54 milligram was the slow drip over 1 hour. On discharge, 1 month later, patient had improved well, could walk without support. His eye movements were normal. He had a mild, persistent memory deficit. And this was the fourth case in the world of artery Percheron IV thrombolysis. This is just going to get published in the next 1 month. The case two was a 78-year-old female, diabetic, hypertensive, mild CKD, creatinine 2, sudden onset facial deviation to the right, slurred speech, and had a left upper limb grip weakness, dropping things from the left hand, noticed at about 5 a.m. when he woke up from sleep. Last seemed normal at 11 p.m. So he was essentially a wake up stroke, and we saw him at about 7 a.m. Sorry, 6 a.m. So he was 7 hours from presumed onset of stroke. On examination, conscious, alert, blood pressure 140/90, dysarthria, left facial upper motor neuron type, left upper limb, left leg drift, and NIHSS of 6. And he showed an MR angiography, the MRI, initially the MRI parenchymal pictures, which tell you that the diffusion is high signal, and the flare was completely negative. And so this is a wake-up stroke, negative flare, diffusion positive. The angio showed us a thrombus in the right MCA. You can see the thrombus right here on the angio. And of course, the ICAs on both the sides, and the MC on the opposite side was open. Basilar was open. There was one, the vertebral on one side was hypoplastic. So at potentially disabling wake-up stroke and with a diffusion flare mismatch, we went ahead, thrombolized her with IV altiplase, 50 milligram total, 5 milligram bolus, 45 milligram over 1 hour. Repeat CT next year, no bleed, recovered well. NIHSS was 1 on discharge, and she did well. So I end my talk when in God we trust, all others have to bring data. So I hand over to Subhash. I apologize. This is my neurosciences team at the Glen Eagles Hospital. I apologize because I have to rush off for an emergency. But Subhash has been very nice to say that he will do the batting and take your questions as well. Thank you very much. Thank you, Subhash, for being such a great friend.
Sure. Thank you. Thank you,
Thanks.
sir.
Thank you so
Shirish.
very
Great
much, sir,
talk.
for enlightening on the importance of the golden hour and also on the differential points that you mentioned in identifying and managing within the golden hour. And also through your experience, through your insights, navigating through the requisites. So thank you very much, sir. It was an honor having you today. Now I hand over the session to Dr. Subhash, sir.
Thank you. Bye-bye.
Yeah. Thank you. Bye. So I
All
will,
the best, Subhash. All the best.
yeah, Shirish. Bye. Bye. I'll just load my presentation. So share screen. And here we go. Yeah, I think you can see it now. Yeah. So Anuja, can I begin?
Yes, sir. Yes, sir. Please.
I'm audible and visible both.
Yes, sir.
Okay, thank you very much. First to Shirish to introduce me to you and for giving me this opportunity, and dear friends who are joined us this evening. Now, the concept of golden hour, as Shirish said, is up to 4.5 hours. But a whole lot of times patients reaches after that golden hour is gone. So after 4.5 hours, you cannot do intravenous thrombolysis, but you can do a mechanical thrombectomy. But mechanical thrombectomy is done if there is a vascular blockage. Without blockage, what will you remove? You have to have a blockage. So how do you suspect that there is a blockage? Well, clinically, if the patient has cortical deficits like aphasia or visual field deficits, this is a pointer that patient probably has one large vessel block. Or if his NIHS score is more than 10, then this is a clue, clinical clue that this patient is probably having a large vessel disease. So even if he comes to us after 5 hours, 6 hours, even up to 24 hours, we can do a mechanical thrombectomy. Now, other than these clinical clues, we can also have a clue on the CT scan. As you can see here, this is a thrombosed vessel. Compare it on the other side. There is a cord-like structure. So if you suspect this thing, these patients should undergo a MR angio, which you can see here. And you can see that there is no vessel seen here. And in these patients, you can do mechanical thrombectomy even up to 24 hours. There are criteria for these, but the most important criteria is size of the infarct. The more you go into 24 hours, the less should be the size of the infarct. And you can see it is small infarct. This is one of my own patients. And this patient, we did mechanical thrombectomy after 18 hours, and the patient recovered very well. And you can see this is a small infarct. And the mechanical thrombectomy is done by a device called solitaire device, by which you can pull out the clot, which you can see here. There are many other devices also. There is a device by which you can suck out the clot. There's a device by which you can pull out the clot, and many times the interventionalists do both the techniques together. So the idea of telling you this mechanical thrombectomy is that this is something which can be done up to 24 hours, provided we identify the clot in a large artery. Now, what is the aim of management after this golden hour or even a golden day has passed? The stroke management does not stop there. The aim is to prevent further progression of stroke, to prevent early recurrence of stroke, to prevent and treat any complications if they occur, and to prepare for physiotherapy, and finally to prepare for discharge. Now, the first thing we have to make sure is that patient's airway should be all right. Now I'm telling you beyond thrombolysis. Thrombolysis is not the only management. That's only first step. But after that, all these things are important. So if the patient has 95% oxygen saturation or less, then he needs oxygen, not otherwise. And patients who are having elective, who are drowsy or who are having raised ICP with bradycardia or papilledema, in them we should have a elective intubation, because otherwise they may get an airway collapse. Now, one of the most important things is that we have to take care of fever, sugar, and their swallowing. These three things have been studied very well in Australia and UK, and it's called FES pathway. We tend to take them very casually otherwise. But the studies have shown that if we take a very assiduous, strict control of these things, this improves the outcome very significantly, which is almost comparable to the thrombolysis. So the protocol says that we must check temperature every 4th hourly. And if it is high, we must treat it and find the cause. We must check blood sugar every 6th hourly. And the nurses should be trained in it. And at any time, if blood sugar is jumping above 140, we should treat it. And all patients, as soon as they come within the hospital, their dysphagia should be screened so that they don't aspirate. But all these things should not be done on 3rd day or 4th day or 5th day. By the time the damage is done, these have to be done as soon as the patient comes to the hospital within the first 72 hours. Now, fever, I said, it's very important because persistent fever leads to high morbidity, mortality. Source of fever should be treated, which is usually in the lungs or urine or skin. And fever should be controlled by antipyretics and antibiotics if necessary. But there's no need of inducing the hypothermia with the new machines. Hyperglycemia worsens the infarct. Sugar enters the infarct and causes damage by causing lactose but sugar should not exceed 140 milligram, and intravenous dextrose is contraindicated in acute ischemic stroke unless the patient is hypoglycemic. And dysphagia occurs in almost half the patients of stroke. It's usually missed, but this is a common cause of aspiration and preventable death, particularly because the family is always very eager to feed. They give all the kinds of water, juice, and all that thing. And I think it's very important that there should be strictly, the nurses should be trained not to allow them to feed unless the dysphagia screening has been done and it has been found that the patient is eligible to swallow. And during swallowing, patients should be conscious. They should be kept upright. And initially, they should be given some semi-solid soft and wait for a minute and to make sure that there is no aspiration. And if there is a problem, then these patients, now these are the things by which you can get a clue that patient may having a swallowing problem. Patient will not tell you, but if you see any slurred speech, facial deviation, secretions coming out, then you suspect that this patient may be having dysphagia, and then such patients may need a nasogastric tube. The advantage of strictly following this pathway is 15.7% advantage towards getting a good outcome and survival at 3 months, which is comparable to a thrombolytic therapy. And imagine if the patient gets a thrombolytic therapy also and this pathway, then the chances of improvement become very, very high. Now, after 24 hours of thrombolysis, patients should get aspirin. And if the patient has not been thrombolyzed, then he can get aspirin on the very first day. The dose of aspirin is 150 to 325, whichever dose you choose. Only in mild strokes, very mild strokes with an NIHS score between up to 5, or in non-thrombolized strokes, we can give double antiplatelet up to 3 weeks to 3 months. And recently a study has come which shows that you can even give aspirin plus ticagrelor 90 milligram twice a day. All patients should be given 80 milligrams of statin at least for first 1 or 2 months, and after that 40 milligrams, and eventually after 3 months you can go to 20 milligrams. Blood pressure is very important. For the first few days, blood pressure should not be touched. If you have thrombolized the patient, then you can bring the blood pressure to 185 by 105. But if you have not thrombolized, then let the blood pressure be 220 by 120, at least for first 2 to 3 days, because suddenly reducing the blood pressure decreases the perfusion to the brain, and the infarct size increases in that situation. Now, once you start treating the blood pressure on the second or third day, either you can introduce the previous BP medication or you can give any new BP medication, but you should not immediately cause a precipitous fall of blood pressure. You should introduce it gradually and slowly. Cardiac monitoring should be done for at least 48 hours to detect any atrial fibrillation or any other arrhythmia, particularly in the right insular and brainstem infarctions. Cardiac arrhythmias are common and they should be detected. Now, dysphagia should not be done only on the day of entry to the hospital. Every day one should check for dysphagia. One should look for the oral hygiene, because that's one of the common causes of nosocomial infections. And respiratory physiotherapy should be encouraged. And suction has to be done in some patients, particularly brainstem strokes. Dehydration should be looked for, because many patients, because of the difficulty in swallowing and other management issues, suffer from euvolemia. Many patients are on diuretics. So dehydration should be avoided. And if there are seizures, then they should be given anticonvulsants, but prophylactic anticonvulsants are not required. And all bedridden patients of stroke must be given subcutaneous heparin or mechanical pneumatic compression. That's very important right from the day one. Otherwise, they are at a risk of getting pulmonary embolism or deep venous thrombosis of the legs. Now, the other thing is that from the second day onwards, the nurse should be trained to do a frequent neurological checkup, a nurse or even a resident doctor. But it is good to train the nurses, because that way they also feel empowered, and they take care they participate in the stroke management. So they have to look for headache and vomiting. Ask the patient, right? Patient may not tell, but they have to ask. They have to look whether patient's sensorium is getting altered. They have to look for seizures. Sometimes these can be very subtle. And they have to every hourly check the pupils. Asymmetry of pupil can be one of the first indications of the swelling of the infarct and the impending coning. And they have to see whether there's any increase in deficits, which means that they should know the baseline deficit. And after that, every hourly, they should ask the patient, show me your tongue, raise both your hands up, lift your leg, so that if there's any increase in deficit, and if there is headache, and if there is asymmetry of pupil, then you have to suspect whether there's any increase in the swelling in the brain. And you can see one example here, that there's swelling of the infarct and it is pressing one of the ventricles. Now, when such a thing happens, then you have to call a neurosurgeon who removes a flap of the brain, flap of the skull. They don't touch the brain. They just remove this part of the skull, which decompresses the brain. It gives the brain the space to breathe. And you can see that the pressure on the ventricle is reduced. Now, decompressive hemicraniectomy has been found to increase the chances of survival, but it does not necessarily reduce or reverse the deficits. And this must be told to the attendants initially, and it's very important, because many times the patient's attendants, even after the surgery, when the patient doesn't walk, they are very disappointed that they did such a major neurosurgery and patient is not improving. So the recommendations are, they should be told that the advantage of the hemicraniectomy is only that it increases the chances of survival and not reversal of the deficits. Reversal of the deficits is a natural process which comes with time along with the physiotherapy. Now, continuous rehabilitation should start from the day one. The patient should be kept anti-spasticity positioning in bed, frequent change of side, skin care to prevent bed sores, and early mobilization. From day 2 itself, we should try to make patients sit up in bed if possible, and even take him into the wheelchair, make him sit up, because that has been shown to improve the chances of long-term independence. But avoid intensive physiotherapy in the first 24 hours. It's harmful. It causes more ischemia. But after 24 hours, you can do intensive physiotherapy. And elastic stockings should not be used to prevent DVT. They are harmful. And as I already said, subcutaneous heparin and pneumatic compression are useful. Now, you must have noticed that more than anything else, the attendants of the patients are very concerned that the patient has not passed motion. So we should be sensitive to that. We should encourage oral feedings by mouth or Ryle's tube, because that stimulates the bowel movements. We should introduce fiber elements and stool softeners. For attendants, these are very important things. But some patients, rather than constipation, are having uncontrolled stools, and to them, for some days, you can give a Imodium, what we normally give for diarrhea. But usually, within a week or 10 days, these issues of constipation and diarrhea are solved. Now, patients also have bladder disturbances after the stroke. So one of the techniques is to tell the attendants to have timed voiding, make them pass urine every 2 hours, like we do for babies. So this prevents the accidents to happen. And no liquids after 6 p.m. so that during night there is minimum formation of the urine. And to men, you can give condom catheter, and indwelling catheter should be either given intermittently or limited to prevent infections. Occasionally, some patients may need some drugs to prevent uh, uh, frequent urination by mirabegron. Now, before we are thinking of discharging the patient, while the patient is in the hospital, we have given him uh, aspirin or double antiplatelets. But before we discharge him, we have to know what caused the stroke. This is very important, because recurrence happens in 5 to 10% of the patients every year. And for preventing recurrence, we have to know exactly what is the stroke mechanism. So all patients should have a minimum of 2D echo and ECG, so that you will look whether there's any atrial fibrillation, which will need oral anticoagulants, so that you will see whether patient's having any clot in the heart, whether there's any akinetic segment, whether patient has any valvular valve, whether patient has any infective endocarditis. So 2D echo is very important. And sometimes if you are suspecting a cardioembolic source, you may even have to do transesophageal echocardiography. But 2D echo is a must. Similarly, all stroke patients have to have a carotid Doppler, because you are screening for a carotid artery stenosis. You know that if a patient is having a more than 50% of the stenosis, and if there's an infarct in the same territory of the stenosis, and if the patient is not dependent, he's independent, it's a non-disabling stroke, then in such patients, we have to offer them carotid stenting or carotid endarterectomy to prevent a recurrent stroke, to improve the chances of avoiding a recurrence. And in all patients, we should also do a Holter monitoring at least for 3 days to detect any paroxysmal atrial fibrillation. So in summary, after the golden hour, which Dr. Shirish Hastak said, which is 4.5 hours, the management of stroke does not stop. We have to look for large vessel occlusion, right, by doing the CT angio or MR angio. And if there is a occlusion, then we can give mechanical thrombectomy option to patient up to 24 hours. Now, after 24 hours, whether the patient has had a thrombectomy or IV thrombolysis, or he has not had it, we have to give antiplatelet agent. And the most common agent, universal agent, which we use for all acute ischemic strokes, is aspirin in the dose of 325 or 150 milligram. Both are equally effective. And eventually, during follow-up, it can be reduced to 75 milligrams. But while the patient is in the ward, in our hospital, we have to make sure that his fever should be controlled, the cause of fever should be addressed, his swallowing should be good, and his sugar should never be allowed to go more than 150 or 160. Patient for first few days should be closely observed in stroke unit. And observed means the things which I said. Look for headache, look for altered sensorium, look for any pupillary asymmetry, look for seizures. And usually 2 to 3 days is more than enough by the time majority of the patients will settle down. And some patients may need a decompressive hemicraniectomy by the neurosurgeon. And then you take the patient from ICU, keep him in the room or ward for a couple of days before you discharge. But before you discharge, you do at least a carotid Doppler and 2D echo to find out the stroke mechanism, whether it's a cardioembolic stroke or whether it's a carotid artery stroke or whether it is simply a small artery lacunar stroke. If it's a cardioembolic stroke, then you will discharge them on oral anticoagulants. But if it's a lacunar stroke, you will give them simply antiplatelet agents. But if it's a carotid artery stroke, then you may consider the option of putting a stent or endarterectomy if the patient doesn't have a disabling stroke. And this is to advise for secondary prevention of stroke. And thank you very much. All of you must be working in your different centers. This is the Indian version of Mona Lisa. And our centers can become as good as any advanced centers if we take so much of pains to create all the facilities. And I have seen very recently, I had gone to one of the districts and I found that their system is so efficient, even though they are in a small district. So it depends upon the will of the doctors who are manning that stroke center. Thank you very much. And I'll be happy if there are any comments or questions.
Thank you so very much, sir. Like you said, in India, mostly patients often manifest post the golden hour, making management a task. So you've already covered and guided us through the entire 360 aspects of management in stroke. So
Yeah.
thank you very much, sir. And with your permission, we have few questions. Shall we take
Sure.
them?
Oh, yes.
So the very first question is from Dr. Anand. So he asks, are there any golden hour nuances for basilar artery stroke?
You see, if you are talking golden hour by golden hour, we mean the first 4.5 hours. So
Right, sir.
broadly speaking, the most of the studies have been done only in the anterior circulation strokes. They have not been specifically done in the basilar artery. So therefore, by extrapolation, whatever are the criteria for the anterior circulation, same criteria apply to the basilar artery also. But recently means as recently as last 1 month or so, there have been some papers which have shown that you can give IV thrombolysis, IV, I mean intravenous, even up to 24 hours, even up to. So that is a nuance, but that is very, very recent. I have myself to survey that literature. So that would be one difference, that the ischemic tolerance of the posterior circulation is more than the anterior circulation. But as of now, today, as far as the guidelines are concerned, they are equal for both. But I think we should look in. I know it has been presented somewhere that for posterior circulation, you can go beyond golden hour also and even up to 24 hours. But only after we check the relevant thing. It's very, very recent, very, very hot. Yeah.
Thank you so much, sir. The next question is from Dr. Afrin. Dr. Afrin asks, how does altiplase compare to tenecteplase in the treatment of acute ischemic stroke?
Whatever data is there, that is showing that tenecteplase is better than alteplase. I mean, if I have to be fair to the data, that is showing that tenecteplase has advantages. Now, I'll tell you what are the advantages. One is that tenecteplase can be given quickly in a bolus. So you don't have to wait. Suppose you are in a small place and you have to shift the patient to another place. So you don't have to ship him with a IV infusion going on. You can just push him, number one. Number second is that the extent study showed that tenecteplase is better in opening the large vessels. So, many times it can spare you mechanical thrombectomy compared to the alteplase. So now what happens is that how our medical system works is that what has been tested in trials is thought to be true. Whatever has not been tested, we say we don't know. So there are some other niche areas, like, for instance, we are saying this, what Dr. Hastak said, wake up stroke. Wake up stroke means that patients who have woken up and you don't know what is the time of onset. So you do diffusion flare mismatch. Now, that study has been done with alteplase. So in the wake up strokes, you'll probably use alteplase. Why? Not because tenecteplase will not work. Most likely that will also work, but the trial has not been done on that. So therefore, in that you will use alteplase till a trial is done. Similarly, these days you can give IV TPA even up to 9 hours. If you do perfusion study and you find that by perfusion, the penumbra is more than the core in a ratio of 1.2, you can give IV thrombolytic agent. Now, that study also has been done only with alteplase. So therefore, there are some areas where you give alteplase rather than tenecteplase. Otherwise, broadly, if you have to remember, they are just the same. There is no difference. They are just the same. That is to be fair to both the molecules. Yeah.
Thank you, sir. The next question is from Dr. Ashwini. Patients with acute ischemic stroke tend to have high BP. So, at what threshold should corrective action to be taken for elevated BP? And what are the agents of choice to control the same?
You see, it's a good question, and I'm happy that she has asked this question, and I'm happy that I have time to answer this. Normally, nobody discusses this thing. As per the guidelines, the BP should not be touched unless it's more than 220 by 120. Except there are some situations where there's an except. Now, the reason why it should not be touched is because when there is an acute stroke, there is a failure of the vasoregulatory mechanism of the brain. So the brain loses its autoregulation. So suddenly those pulsatile, nice, compliant intracranial arteries become paralyzed. So therefore, they have lost their pumping capacity. So if you reduce your blood pressure from 200 to 160 at that time, there will be no perfusion to the brain. Normally, perfusion is maintained by the pulsatility of the vessel. The vessels contract nicely, contract and dilate, contract and dilate. That is the autoregulation. But when there's an acute paralysis, there's a paralysis of the blood vessels also. So, the blood vessels are in a state of shock, so to say. So, therefore, it's recommended that for first 48 to 72 hours, let us say we'll keep it 48 hours, don't touch the blood pressure. Now, there are only some, how much don't touch your question threshold? 220 by 120, which means even if you have got 210 by 110 or 115, don't worry about it. Don't do anything about it. Just treat his pain, treat his anxiety. Many times this BP is not real, it's reactionary. It will automatically come down. But after 2 days, you will worry about it and then start treating. Now, there are some exceptions where you will treat it on the day one itself. Number one is if you are thrombolizing the patient, because high blood pressure itself is a predictor of bleeding post-thrombolysis. So there you will bring it to 185 by 110. And after you have given the thrombolytic agent, you will bring that 110 to 105 because you are very worried that he should not bleed. And there are some other exceptions also where you have to reduce the blood pressure. That is, if the patient is having a simultaneous myocardial infarction, simultaneous acute kidney failure, simultaneous aortic dissection, simultaneous acute kidney failure. Now, as you realize, all these situations are rather uncommon, but you have to look for them. Only in those cases you will reduce the blood pressure, not to the rock bottom, but to same 180 by 110. Otherwise, don't worry about it till 2 days, and after 48 hours, gradually start reducing them. Yeah.
Thank you so very much, sir. The next question is from Dr. Praneeth. Like you've already covered it, sir. In India, most patients often manifest post the golden hour. So, what should be the key awareness for both patients and clinicians? And there's also one more question, which is what would be the primary care to be done at the primary level before referring the patient?
You see, the first thing is that you have to know, is it a brain hemorrhage or a brain infarct? Because unlike MI, these patients often ask that, can we give something? Patients only ask, if there's a paralysis, what will you give immediately? Unfortunately, you cannot give anything because in MI, there is no myocardial hemorrhage. Here you have got a myocardial, here you have got a brain hemorrhage or brain ischemia. So therefore, you have to have a CT scan. So I think if you are in a primary center, and if a patient has any acute neurological deficit, the best you can do at that time is to make sure don't give him anything by mouth. Tell patient, this is the commonest cause of mortality. When the patients land in our hospital, they land with pneumonias, so which kills them rather than the stroke. So the best one can do at a primary center is that the moment patient has a hemiplegia, first of all, suspect that it could be a stroke make sure you can do a blood glucose at least. Make sure that it's not a hypoglycemic hemiplegia, which sometimes is a cause, and make sure that you do basic clinical examination, that it's not a post-ictal phenomena. Many times focal seizures can cause Todd's palsy and they look like a stroke. But having done that clinical examination, then just make sure the attendants don't feed him and just send him to the nearest place where CT scan can be done. CT scan is a must because sometimes subdural hematoma mimics a stroke, right? Brain hemorrhage is something else. Ischemic stroke is something else. Very rarely you will have even encephalitis and things like that causing like hemiplegia. So I think from the primary physician, make sure that if you have got the facility and if you have got, make sure that his airway is secure, he's breathing, right? His BP should not be lowered. There's a reaction on the part of physician. Once he will see 210 and 110, he will give him sublingual nifedipine. Don't do it. BP has not to be touched. Make sure he has a proper airway and not to be given anything by mouth, and send him to the nearest district where the CT scan can be done. And after that, he can be taken care. And of course, oxygen can be checked anywhere. If in the primary health center, you can see that his oxygen is less, then better to send him with oxygen. If the oxygen is less than 95 or less than 90. There was some other part of the question which I have missed. What was the other part of the question other than what can a primary physician do? There was one more part of
What
this.
would be the key awareness for both patients and clinicians?
No, the key awareness for patients and anything that any sudden change in your function, it can be a stroke. Any sudden change. If you must have seen those slogans. If it is fever, it can be malaria, right? So if it is any sudden change in your behavior or in your power or in your any action, sudden change, it can be a stroke. Now, many times it may not be a stroke, but that's okay. That's a good news because we don't want to miss the golden hour. Whatever has to be done, it has to be done within that 1 hour. It's no use if the patient meets us after 2 days, 3 days. By the time the damage is done. Yeah.
Right. So if you could say for a layman, it would be sudden changes in any
Yes.
of his
Yes.
functions.
Any
Right.
of his
So
functions, physical or mental.
mental, right.
Sometimes it can be just behaving like a mad person because he has got he doesn't comprehend anything. That is a sensory stroke. What's called, posterior parietal strokes are like that. So any sudden change in function, physical or mental, can be a stroke. Yeah.
Right. So thank you so much. And the next question is from Dr. Vinayak. Atrial fibrillation with cardioembolic ischemic stroke. When can NOACs be safely started and the key clinical pearls for the same?
You see, the thing is that there's a rule for that called Diner's law. And basic principle of that is that it depends upon the size of the infarct. Why we are afraid of starting these oral anticoagulants is that there's an impression that if you start them too early, patient will bleed. And the chances, the brain will bleed. The chances of bleeding of the brain depend upon the size of the infarct, how big the infarct is. So if the patient has a TIA and brain does not have an infarct, you can start it on the day 1 itself. If the patient has a small infarct means less than 1/3 of the MCA, you can start it on the 3rd day. If the patient has almost half the MCA, half of MCA distribution, you can start it safely by 1 week. But if the patient has a big entire MCA is involved, then it is better to start it at 2 weeks. Now, recently, there are many papers which are coming. They are saying that you can even start it earlier than this. But to be on the safer side, I think this Diner's law of 13714 is good enough, uh, which I have already explained to you. Yeah.
Right. So shall we take the further questions or shall
Oh,
we?
yeah. I'm ready. I'm ready. Depends on
Sure,
you.
sir. So the next question is from the Dr. Shoaib. Dr. Shoaib asks, the clinical placement of dual antiplatelet therapy in stroke care, when to start, when to hold off, and how long to keep it going?
See, just remember that dual antiplatelets have to be given only for strokes which are minor strokes. And by minor strokes, we mean clinically minor, which means NIHS is 1 to 4, not more than that, because then there's a chance of bleeding. So to give an example, mild dysarthria, just one hand weakness, mild limp. So anything which causes NIHS, less. And it should be non-thrombolized patient. In thrombolysis, they are not to be given, unless very exceptionally. Otherwise, you don't give it. So minor stroke and non-thrombolized strokes, you can give it. Now, how long to give it? See, up to 3 weeks, you should give to everybody. That there is no problem about it. Up to 3 weeks, double antiplatelets. And if you are giving, but if you are dealing with intracranial atherosclerosis, which means that your MCA is it is having intracranial atherosclerotic disease. That means it is rough and blocked and all. In that case, you can go beyond up to 3 months also. Only thing, remember, double antiplatelets, you can give 2 combinations, either aspirin plus clopidogrel, which you can give 3 months or 3 weeks, depending on whether there's an intracranial stenosis or not. But if you are giving ticagrelor, because these days ticagrelor is being used quite widely, that combination should be given only up to 1 month. And again, for the reason that the trial has been done only for 1 month. The Thales trial was done only up to 1 month. So therefore, that can be given 1 month. And generally, this double antiplatelet is given to prevent the early recurrence. And early recurrence chances are highest in the first 1 month or first 3 weeks. After that, the endothelium cools down and the swelling of the endothelium is less and chances of less. Because the chances of bleed become more eventually. So I would say as a general rule, definitely up to 3 weeks. But in some patients, you can go even up to 3 months, except ticagrelor, which you should give only up to 1 month. Yeah.
Sir. So shall we take the last question for the day then?
It's up to you.
Sure, sir. So Dr. Madhu asks, how many of your acute ischemic stroke patients need Holter monitoring to detect a silent atrial fibrillation?
I'm very surprised Madhu asked this question. I don't know. I think he's probably read my mind. We have done a research on this and we have not detected. We did in about 60 patients Holter monitoring for 2 weeks, and not even in 1 we could detect atrial fibrillation. The ones in which we detected, only 1 patient that we detected in the first day itself. So the bottom line is that you should monitor them clearly for 2-3 days, because if this stroke has happened because of paroxysmal atrial fibrillation, then you should detect it in that area within first 2-3 days. You should detect it. But if you don't detect it in 3 or 4 days, then as per experience, 2 weeks is too less a period to detect it. At least we have not detected in 60 patients. And the studies have shown that if you do the monitoring for 3 years, and there is data where people have done for 3 years, they have detected only in 30%. So the yield is not very high, but it's worth doing, particularly in ESUS patients where you don't have a mechanism. But don't be disappointed if you don't find in 2 weeks. That's why these days there are very long-term monitoring, 6 months also, 1 year also in some patients. Yeah, I'm happy you asked that question. Yeah.
Thank you so very much, sir, for answering all the questions so elaboratively and sharing your experience as well. So, sir, with your permission, I would like to end the session then.
Thank you.
Once again, on behalf of the organizing team and the medical affairs team at Macleods, I extend my gratitude to you and to Dr. Shirish. We are grateful for your time and dedication to improving stroke care in India. And we also look forward to seeing the continued impact of your work.
Thank you.
Thank you once again for being
Bye.
with us and making this session so enlightening, sir. Have a great weekend and greetings of the season.
Happy Diwali. Thank you.
Also, thank you to our audience and especially to our DocMode team for hosting us so well. So thank you, everyone. Have a great evening.
Thank you.